I'm Dr. Lyle Joyce, Professor of Surgery at the Mayo Clinic, Rochester, from the Division of Cardiovascular Surgery. Today I'm going to talk with you a little bit about the evolution of mechanical circulatory support devices. Now, this story would include many facets from all around the world, and today I'm going to share with you some of my personal experiences over the past half century. Anytime anyone talks about the beginnings of mechanical circulatory support devices, I think one has to almost always include this name, Dr. Michael DeBakey. Dr. DeBakey was a very famous surgeon from Baylor College of Medicine, and I had the good fortune of being one of his students when I was a medical student. Here is a picture of Dr. DeBakey giving me my MD diploma at the time of graduation. But Dr. DeBakey was not only a great cardiac surgeon, he was an inventor as well. And in fact, as early as 1954, he developed the DeBakey roller pump, which would become the pump head for virtually every heart-lung machine in the world in the near future. It was during these days, during my childhood, that I was reading stories about the great things that Dr. DeBakey and Dr. Cooley and others were doing, Dr. Lullahy up here in Minnesota. And I think it was these sort of events that really generated my interest in cardiac surgery, to the point that I knew that I was going to be a cardiac surgeon by the time I was a freshman in high school. Now, not only was it important that Dr. DeBakey was a good surgeon and an inventor, but probably equally important in this historical cascade of events was the fact that he was very influential on Capitol Hill. In fact, he testified in Congress in 1963, and he said at that time, experimentally, it is possible to replace the heart with an artificial heart, and animals have been known to survive as long as 36 hours. He said, this idea, I am sure, could reach full fruition if we had more funds to support more work, particularly in the bioengineering area. And here we see a picture of President Lyndon Johnson congratulating Dr. DeBakey for having successfully managed to get the National Heart and Lung Institute to establish something that was called the U.S. Artificial Heart Program. Now, this meant that U.S. funds, government funds, would be poured into research to try to develop some kind of a total artificial heart or assist device. And this was Dr. DeBakey's response to the press after that.
My major goal now, as far as my research work is concerned, is to perfect the artificial heart.
Dr. DeBakey got off to a fast start. In fact, by 1966, he had developed this ventricular assist device that he first successfully used as an LVAD in a patient who he replaced the aortic and mitral valves, but unfortunately would not wean from cardiopulmonary bypass. He placed this temporary LVAD as a bridge to recovery, and the lady had this device in place for a matter of several days. Her heart did recover. He explanted the pump, and she actually lived for many years. In fact, she didn't have any further cardiac disease. She eventually died, unfortunately, from a car accident. But this was a first successful use of a ventricular assist device. Now, just to set the timetable in order, I need to remind you that the first human orthotopic heart transplant was carried out by Dr. Christian Barnard in December of 1967 in Cape Town, South Africa. And of course, there was a tremendous interest in moving that field forward. In fact, in 1968, there were 102 heart transplants done in 17 centers around the world. Unfortunately, the results were disastrous. In fact, here's a picture of 6 of Dr. Cooley's transplant patients, all posed for the front of Life magazine, only to learn that all 6 of them would be dead within the next 8 years. So the reality was, during the attempt to develop ventricular assist devices or total artificial hearts, the thought was that these devices were going to be permanent devices, not as bridges to transplantation. I had the good fortune of being able to work with Dr. DeBakey in his lab in the summer of 1968, and at that time he had Dr. Domingo Leota developing this total artificial heart, and my job was to clean up the surgical instruments after he and Dr. Liotta had implanted this total heart in calves, and then during that night after surgery to try to keep the animal alive. Unfortunately, we were never successful. All of the animals were dead by the next morning. I went back to college in the fall of 1968 and was surprised to hear that Dr. Liotta and Dr. DeBakey had parted ways later in that year. And it wasn't until many years later when I was on a symposium with Dr. DeBakey in Sacramento, California, that I really found out the truth from him. I asked him, well, why did you and Dr. Liotta leave? And what Dr. Liotta had done was take his heart and move across the street and join Dr. Cooley, who said he would perfect it further. Dr. DeBakey told me that it was in December of '68 when Dr. Liotta had brought an abstract to him to review, which was to be sent in for the American Society of Artificial Internal Organs meeting in May of 1969. And this abstract stated that he had 12 out of 16 animal survivors. Dr. DeBakey says, Dr. Liotta, this isn't true. You have no survivors. And he said, well, Dr. DeBakey, at the rate that we're going, I'm certain that by the time the meeting comes around in May of next year, we'll have at least 12 out of 16 survivors. Dr. Cooley said that wasn't right. I fired him. Well, I was very surprised then on April 9th of 1969 to learn that Dr. Denton Cooley implanted this total artificial heart in a gentleman who he had carried out a coronary bypass procedure on and resected a left ventricular aneurysm. Again, a patient who couldn't be weaned from cardiopulmonary bypass. And he used this heart to bridge this patient to a transplant. Now, lo and behold, this patient lived for 64 hours. You can see the chest x-ray here with the total artificial heart in the normal position. And this patient woke up, was extubated, mentated normally. His kidneys worked well, lungs worked well. And this was really quite surprising because this was a pump that was never successful in keeping an animal alive for 24 hours. He transplanted the patient a few hours later, or a few days later, and that patient did die shortly thereafter of complications of pneumonia. This set up a huge feud between Dr. DeBakey and Dr. Cooley. In fact, this feud would continue on for the next 45 years. And the FDA made some changes by and large as a result of the feud that lasted. It was just a furious battle between the two of them. And the FDA then set up a regulation for medical devices such that it required animal studies showing reasonable assurance of safety and effectiveness. And we still live with this mandate today, which by and large has been helpful from the standpoint of making sure that the devices are well suited for human use at the time they go into effect, but has been really somewhat detrimental to us and has allowed Europe to get ahead of us in this field on many occasions. Well, I moved to the University of Utah to do my cardiac fellowship, and one morning Dr. Bill DeVries called me and he says, let's go out to the old St. Mark's Hospital. We're going to implant a Jarvik 7 total artificial heart in a calf. And I was really quite surprised to walk into the old St. Mark's Hospital, which had been converted into an animal lab, to see Dr. Willem Kalf here, who was the inventor, the real inventor of not only the total artificial heart, but the dialysis machine during the World War. And here he's shown with Frederick, one of his prized sheep, and if you look closely, you can see a couple of air hoses coming out the side of Frederick, and Frederick had had this Jarvik 7 total artificial heart in his chest for about 6 months. And on beyond this picture are about 12 more cages of various calves and sheep at various stages of their implants, undergoing various kinds of testing, some of them on treadmills and some of them having other types of tests done. I was shocked at how far Dr. Kolff had gone from 1957, when he was at the Cleveland Clinic working with Dr. Akutsu with this first little heart here, which was the first successful animal implant, keeping a dog alive for 90 minutes. But that was the first implant of a total heart, and he'd gone through all these different renditions until he'd gotten down to the Jarvik 7 total artificial heart. Well, everything was a race in those days. In the 60s, it was a race to see who would land on the moon and first orbit the Earth, and it was a race to see who would be the first to transplant a heart, the first to put a total heart in. And Dr. Cooley was very much in that race, even though we were having a lot more success in Salt Lake City. In fact, here's Lillian, the sheep. Lillian has a total heart in place, and you can see down in front, we actually had a portable driver called the Heimless driver. And this driver was portable enough that we could put it in saddlebags, which we did, put it on her back, and release the tie rope. And Lillian took off on a dead run. In fact, it took us a while to catch her. She was so mobile with her new total artificial heart. Now, I might add, we knew that we weren't going to have to struggle too long because we only had 2-hour batteries in the portable driver, and she would stop in a hurry if we waited that long. But we were really having great success with this device. Dr. Cooley, however, wanted to race ahead, and by now Dr. Akutsu had left the Cleveland Clinic and joined Dr. Cooley in his lab building another total artificial heart. And Dr. Cooley, as he liked to do, was very happy to have the press join him in the operating room and let them see everything that was taking place. He invited Life magazine to photograph this entire event. And as many of you may remember, Life magazine was noted for its beautiful pictures. In fact, we bought the magazine for the pictures many times. And the entire procedure was outlined in Life magazine, but unfortunately, Dr. Cooley had one problem, and that was the heart was too big for the man's chest, and the center picture in Life magazine was this picture of the patient on the operating room table with the chest open, draped with an Ioban drape, and the patient stayed here until Dr. Cooley could find a donor heart to transplant, which he did, and this patient also died a short time after from complications. But this was the stage that was set at the time that Dr. DeVries and I implanted the first total artificial heart on December 2nd, 1982. Now, we were fortunate to have a volunteer, if you will, who was a dentist, Dr. Barney Clark, and Dr. Clark had come down to the hospital, watched Dr. DeVries and me implant the total artificial heart in a calf in September of that year. And he made his decision after watching the calf wake up and seeing how well the other calves were doing and sheep were doing, made the decision that at the time of his demise, he wanted to have a chance to have the Jarvik 7 implanted in his chest as a permanent device. He was turned down by 3 centers, which was required by the FDA for transplantation, and had decided to return to Utah when it was necessary. It was Thanksgiving weekend that he was flown in with multiple problems of ventricular tachycardia. He arrived, we managed to get him out of ventricular tachycardia and have him go through the 11-page consent form, which was to be signed on 2 occasions, 24 hours apart. And once that was done, we were all set for surgery on Monday morning. Unfortunately, he went into VTAC again Sunday night, and we couldn't get him out of it. So we rushed him to the operating room, and we began the surgery at midnight on December 2nd. Now, the heart is implanted, as you could see from that previous x-ray, in the normal anatomical position. We resect the ventricles, save the atria, sew on some cuffs to the great vessels and to the atria, and then connect this total artificial heart to the device. Just to give you a little idea of just how long ago that has been, this is a picture of Dr. Clark, Mrs. Clark, and his daughter and son-in-law with 3 of my children on Christmas morning. It was my daughter, Sherry Crow, now is a pediatric intensivist here at the Mayo Clinic, and David Joyce is a cardiac surgeon here at the Mayo Clinic. So this has been many years ago. We were surprised at just how much interest there was in this by the media. In fact, the entire cafeteria was overtaken by various types of media people from around the world. They actually put up tents and camped out all the way through Christmas, all the way through New Year's, well into late January before they finally began to disperse a little bit more. There were 2 press conferences a day, and of course they were constantly wanting him to get better and better. So it was a real battle of trying to release as many actual facts as we dare, and yet not have the media just going bonkers over how well he was doing. But Dr. Clark really did do quite well for 112 days. In fact, he had another Christmas, another New Year's, another birthday, another Valentine's Day, another wedding anniversary shown here with his big wedding anniversary cake. And these were all days that he would have never seen had he not had the total artificial heart. And days that by and large he enjoyed. In fact, he died not from complications of the heart, but complications of bacterial overgrowth in the bowel, secondary to the fact that we were probably administering him far too many prophylactic antibiotics. But Dr. Clark had some other situations that weren't ideal. One was he was connected to this 460-pound driver, and it was obvious that while he had volunteered for this and knew that he was going to die on this device, if he had had his druthers, would have been on the golf course. And he knew that this was never going to happen without a portable driver, which we didn't have in those days. And the press came up with many jokes. Of course, one was the Tin Man from The Wizard of Oz. He says, "Go ahead, follow the yellow brick road. I'm going to the University of Utah Medical Center to get my heart." Well, the enthusiasm about total artificial hearts grew rapidly. In 1986, there were 41 implants in the world, and by that time, there were 30 different centers worldwide that were implanting total artificial hearts of all kinds. In fact, there were devices that had been tested in animals and some devices that hadn't been tested at all. We kept a registry with all of the total artificial hearts that were implanted worldwide for the next 10 years. So I was literally aware of all the complications and of all the implants that were taking place. And this was very fruitful in being able to keep on top of what was happening as far as progress clinically, and also helping others with the interchange of ideas from one center to another. I left the University of Utah and came to Minnesota in 1983. Dr. DeVries left in 1984, moved to Louisville, Kentucky, and each of us, as well as several other centers in the country, wanted to set up new centers to implant devices. As a consequence, the FDA shifted the paradigm on us, and they decided that the only way we were going to be able to use devices in the future was as a bridge to transplantation rather than destination therapy. I'm convinced to this day that the real reason they did this was that they were afraid things were getting out of hand and that we were going to shut this process down, because who would take a critically ill patient who had just gone through the implantation of a mechanical device and then turn around and put the patient through another operation transplanting a human heart? There were just too few hearts available to do that. Little did they know that this would not be the case. Just the opposite would happen, and we would prove that devices were actually helpful in getting patients better in shape for heart transplants. Had many good friends around the country using other devices. Here was Pierre Portner and Phil Oyer at Stanford, who were working with a Novacor left ventricular assist device, not a total artificial heart. Don Hill at UCSF had these pumps that were developed by Thoratec. that were being tested, and they all had similar problems. They either had external attachments or huge drivers that we had to deal with. Here's the driver for the Thoratec pump, very similar to the one for the total artificial heart. Dr. Bud Frazier down in Houston with Vic Poirier had a TCI pump that Thoratec eventually purchased. And in 1986, this pump was approved for a study by the FDA called the rematch trial. And now, for the first time, we were able to prove that using the total artificial heart was more successful than medical treatment. In fact, at the end of 2 years, 23% of the patients were alive with the ventricular assist device, a pulsatile device, whereas only 8% of the patients who were treated medically were still alive. One of the problems, though, with all the moving parts in these pulsatile devices was that they wore out. And this particular pump had to be changed out about every year to year and a half because there was something about the device that was failing. And of course, even the Tin Man knew that hearts will never be practical until they're made unbreakable. We were fortunate from the total artificial heart standpoint that while the Jarvik 7 heart was a very large heart, too big for many of our chests, the company came out with a smaller version. This is what we called Jarvik 770 at that time, which was 30% smaller. Now, they sent the device out to us to sterilize, and we assumed that since the device was identical to the larger device, that the FDA would allow us to implant it in humans. However, that was not the case, and the FDA notified the company and said this was not going to be allowed until they did another series of animal implants, too many animals for the company to survive financially. So the company called us and said, send the pumps back, and I had a couple of these pumps on the shelf, sterile, here in the Twin Cities, and I was frustrated because I knew that the likelihood of the first patient being too small was very great. And I asked the company, I said, well, what can we do if we have a patient that is too small? And they said, well, the FDA said that we could you could call us, we could send a pump out, you could sterilize it, and if they gave us approval, then you could use it as a humanitarian device or just a urgent device to salvage a patient's life. Well, we knew that that wasn't very practical because these devices had to be gas sterilized in those days, and it took 30 days from the time of sterilization until they could be implanted in a chest. The company had just hired a new CEO from Medtronic, and he moved to Salt Lake City, but his family decided to stay in the Twin Cities until their son, who was a senior in high school, finished his high school graduation and then would move back to Salt Lake City with them. So I theorized with the CEO and I said, listen, if you take this pump in its sterile package and keep it at your house here in the Twin Cities, we will be abiding by the FDA rules. It'll be in the hands of the company, and yet if a patient comes along that I have to have it for emergency use, we could get it here in time. He agreed to do that, and sure enough, our first patient was a very small lady, Mary Lund, and she literally was dying the evening that she came in, and I knew that she would never be alive by the next morning if we didn't have a device to use. I called the company and they said, well, you'll have to call the FDA and get approval. So I called the FDA that night about 11 o'clock in the evening and got a deputy on the line and explained exactly what I had done, how we had abided by the rules, and that we had a device that we could use. The phone went completely dead. In fact, I thought he had hung up on me, and then finally this voice came back on and it said, well, Doc, I guess you know what you have to do. Good luck. And we implanted the heart in her, which fit nicely, and it worked as well as the larger pump. In fact, A few months later, the FDA approved that pump without any animal experiments, and we were able to go on and implant it in other people, including this youngest boy ever to have a total artificial heart, Chris Larson, and we successfully transplanted him. He's still alive, doing quite well. In the back of our minds, though, was this dream of a totally implantable pump. And that hope was kept alive because we had the memory of this picture on your left in the back of our minds. And some of you, historians, will recognize this. This was the first pacemaker in 1957. And of course, we knew what happened to pacemakers. Pacemakers now are so small, they're under the skin, and we never know people even have them. And we had dreams of the driver for a ventricular assist device or a total artificial heart being just that small. It likely was not going to happen with pulsatile devices. And we were fortunate then to have an experiment done by Dr. Rich Wampler, who was an inventor and a cardiac surgeon as well. He came up with this impeller that could be put inside of a silastic tube and sent it up through the aorta, through the aortic valve, down into the left ventricle, such that blood would literally be augured out of the left ventricle and distributed into the ascending aorta. Now, this little impeller spun at about 25,000 RPM. Now, anyone in their right mind would assume that this literally would make Kool-Aid out of blood. It would fracture the red cells and never would be successful. Much to our surprise, there was very little hemolysis at all. And that led us into a whole new area of building smaller pumps, continuous flow pumps, which would allow us to have smaller devices. The first one to come out was the DeBakey LVAD, which you can see here is so small that it fits in the palm of your hand. It would fit within the pericardial cavity, and even the driver now could be smaller. In fact, my first patient here, who is being discharged from the hospital, is marveling at how much larger the cam recorder case is that my son brought in to take a picture of him before he went home than his driver. There were other pumps being developed with a similar type characteristic. This is a Jarvik 2000, an impeller that fit right within the ventricle. The Thoratec company would come up with a HeartMate 2, which in fact became the most successful device, and it allowed us to carry out another study similar to the rematch trial, but now comparing the continuous flow, the HeartMate 2 device, with the old pulsatile device. And whereas the 2-year survival with the old pulsatile device was about the same, 24% at 2 years, we now had a 58% survival with the use of the new continuous flow device. And you can see here the difference between the two devices, with the pulsatile device having 2 valves and a pusher plate that goes up and down, as opposed to the continuous flow device, which has an impeller and blood being spun directly through the pump in a straight line fashion with only 2 bearings in place, no other moving parts. Another company, Heartware, came up with a new style device. This was something called a centrifugal pump, which meant blood comes in through one end and is spun out at 90 degrees in the other direction. Now, this was a floating impeller, a hydrodynamic bearing, and it was implanted in the chest, pretty much like all the other devices are, with the inflow cannula being placed in the tip of the left ventricle and the outflow cannula being connected to the ascending aorta. Both of these devices, the HeartMate 2 and the Heartware device, are being used many times a month throughout the world today with great success. You can see the chest x-ray here, which really looks quite normal with the pump in place. All of these devices still have the one drawback, however, and that is the power source has to come out through the skin through an electrical cord. But even the total artificial heart has made great strides in that now we have a portable device called the Freedom Driver, which is much smaller, only about 15 pounds compared to this 400-pound device. And you can see here a picture of our first patient here at Mayo before he's going home on an outing with his sister with his driver in a backpack. What's the future? Well, we will be testing at least 4 new pumps in the next 5 years. And minimally invasive implantation will certainly become the norm. Totally implantable systems are being tested in the lab, and I think will come to the clinical arena in the near future. And devices will be smaller and available for pediatric use as well. Devices will be implantable in earlier stages of heart failure, and we'll have the hope that we can put it in, by putting it in earlier, we will be able to have a better chance of having myocardial recovery. Just a few pictures here of the various kinds of pediatric devices that are being investigated under NIH support. And yes, we may even have total artificial hearts that are not pulsatile devices, but are small axial flow or centrifugal flow devices that can be sewn in the chest as we would a pulsatile device, but something that would be able to be implanted even in smaller children. Well, I thank you for listening to this discussion today, and I hope that you will join us on some of our future grand rounds.